Block simulation 7. Same process, fresh material. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. What is the underlying enzymatic defect? A 22-year-old man of Mediterranean descent develops fatigue, jaundice, and dark urine 2 days after starting trimethoprim sulfamethoxazole for a urinary infection. Labs: Hb 814, indirect bilirubin elevated, LDH high, haptoglobin low. Peripheral smear shows bite cells and Heinz bodies on supravital stain. Read the command, underlying enzymatic defect, acute hemolysis after an oxidant drug, bite cells, Heinz bodies, Mediterranean descent, G6PD deficiency. Glucose 6-phosphate dehydrogenase is the rate-limiting enzyme of the pentose phosphate pathway, which generates NADPH. NADPH keeps glutathione reduced, and reduced glutathione is the red cell's main defense against oxidative stress. When G6PD is deficient and the cell is hit with an oxidant, sulfa drugs, antimalarials, fava beans, or infection, the red cells cannot regenerate glutathione. Hemoglobin oxidizes and precipitates as Heinz bodies, and splenic macrophages bite out those inclusions, creating bite cells. The result is an episodic oxidant-triggered hemolytic anemia. The correct answer is C. G6PD deficiency is X-linked recessive, most common in those of Mediterranean, African, and Asian descent, and is protective against malaria. The classic trigger list is the oxidant stressors. Test for the enzyme weeks after the episode, not during, because the most deficient cells have already lysed. Heinz bodies plus bite cells after an oxidant is the signature. What best explains the discrepancy between a normal PaO2 and tissue hypoxia? A 40-year-old man is pulled from a house fire. He is confused with a headache and nausea. His skin is cherry red. Pulse oximetry reads 99% and PaO2 on ABG is normal at 95 mmHg, yet he is clearly hypoxic at the tissue level with an elevated lactate. Read the command, explain the normal PaO2 with tissue hypoxia, house fire, headache, cherry red skin, falsely normal pulse oximetry, normal PaO2, but tissue hypoxia, carbon monoxide poisoning. Carbon monoxide binds hemoglobin with about 200 to 250 times the affinity of oxygen, forming carboxyhemoglobin. This does two damaging things. First, it occupies the oxygen binding sites, so hemoglobin carries far less oxygen even though the PaO2, the oxygen dissolved in plasma, stays normal. PaO2 measures dissolved gas, not what is bound to hemoglobin, which is why it reads normal here. Second, CO shifts the oxygen hemoglobin curve to the left, so whatever oxygen is bound is held more tightly and not released to tissues. The result is severe tissue hypoxia with a deceptively normal PaO2. The correct answer is D. Standard pulse oximetry cannot distinguish carboxyhemoglobin from oxyhemoglobin, so SpO2 reads falsely normal. You need co-oximetry to measure carboxyhemoglobin directly. The cherry red skin and the normal PaO2 with tissue hypoxia are the classic clues. Treat with 100% oxygen or hyperbaric oxygen in severe cases to displace CO. The deficient nutrient is a required cofactor for which reaction? A 58-year-old man who lives alone and eats a diet devoid of fruits and vegetables presents with fatigue, bleeding swollen gums, loose teeth, parafollicular hemorrhages, and corkscrew body hairs. He also has poor wound healing and bruising. Read the command. Which reaction needs this cofactor? Poor diet, bleeding gums, parafollicular hemorrhage, corkscrew hairs, poor wound healing, scurvy, vitamin C deficiency. Vitamin C, ascorbic acid, is the required cofactor for prolyl and lysyl hydroxylase, the enzymes that hydroxylate proline and lysine residues during collagen synthesis. This hydroxylation is essential for the cross-linking and stability of the collagen triple helix. Without vitamin C, the body produces weak, defective collagen. Because collagen is the structural protein of blood vessel walls, gums, skin, and connective tissue, the deficiency causes fragile vessels, bleeding gums, parafollicular hemorrhages, easy bruising, plus poor wound healing and the corkscrew hairs. The correct answer is A. The defective collagen explains every finding in scurvy through the lens of weak connective tissue. Choice B, gamma carboxylation, is vitamin K's role. Choice D, homocysteine methylation, involves B12 and folate. Vitamin C also aids iron absorption and acts as an antioxidant, but the collagen hydroxylation defect is what produces the classic scurvy picture. Which nerve was most likely injured? A 35-year-old woman undergoes a radical mastectomy with axillary lymph node dissection. Postoperatively, she notices that when she presses her arms against the wall, the medial border of her right scapula lifts away from the chest wall, a winged scapula. She also has difficulty raising her arm above the horizontal. Read the command. Which nerve was injured? Axillary surgery, winged scapula, difficulty raising the arm above horizontal, long thoracic nerve injury to serratus anterior. The long thoracic nerve, roots C5, C6, and C7, innervates the serratus anterior muscle. The serratus anterior holds the scapula flat against the thoracic wall and rotates it upward to allow arm abduction above the horizontal. The long thoracic nerve runs superficially along the lateral chest wall in the axilla, making it vulnerable during axillary lymph node dissection or mastectomy. When it is injured, the serratus anterior is paralyzed. The medial border of the scapula lifts off the chest wall, winging, especially when pushing against resistance, and the patient cannot fully abduct the arm overhead. The correct answer is B. Remember the mnemonic C5, C6, C7, raise your wings to heaven. The long thoracic nerve roots, serratus anterior, winged scapula. Its common iatrogenic cause is axillary surgery. Choice C, the spinal accessory nerve, also causes scapular problems via trapezius, but the classic medial winging from pushing against a wall is the serratus anterior and long thoracic nerve. What is the predominant mechanism of his airspace disruption? A 62-year-old man with a 45-pack year smoking history presents with chronic progressive dyspnea and a chronic cough. He is thin, breathes through pursed lips, and is barrel-chested. Chest imaging shows hyperinflation and flattened diaphragms with predominantly upper lobe destruction. Pulmonary function tests show airflow obstruction with increased total lung capacity and decreased DLCO. Read the command. Predominant mechanism of airspace disruption: heavy smoker, barrel chest, pursed lip breathing, upper lobe hyperinflation, low DLCO, centriacinar emphysema from smoking. Emphysema is destruction of the alveolar walls, and the central mechanism is a protease, anti-protease imbalance. Cigarette smoke recruits and activates neutrophils and macrophages in the lung, which release elastases and other proteases that digest the elastin in alveolar walls. Smoke also generates oxidants that inactivate alpha-1 antitrypsin, the main antiprotease that normally restrains elastase. With proteases unleashed and the antiprotease disabled, alveolar walls are broken down, airspace is enlarged and lose elastic recoil, and gas exchange surface is lost, lowering the DLCO. The correct answer is A. The location is a clue to the cause. Smoking-related emphysema is centriacinar and upper lobe predominant, whereas alpha-1 antitrypsin deficiency causes panacenar, lower lobe emphysema, often in younger non-smokers, and is associated with liver disease. Loss of recoil also explains the pursed lip breathing, which keeps airways open during expiration. The elastase-anti-elastase imbalance is the unifying mechanism. What best explains the initially high serum potassium despite total body depletion? A patient in diabetic ketoacidosis has a serum potassium of 5.6 mg/kg on admission, yet the total body potassium is severely depleted. As insulin therapy is started, the serum potassium begins to fall rapidly. Read the command. Explain the high serum potassium despite total body depletion. DKA with paradoxically high serum potassium that falls with insulin. Transcellular shift. This is the classic potassium paradox of DKA. Two forces drive potassium OUT of the cells into the serum. First, Insulin deficiency. Insulin normally pushes potassium into cells by stimulating the NBME pace, so without insulin, potassium stays out. Second, acidosis. As excess hydrogen ions enter cells to be buffered, potassium is exchanged outward to maintain electron neutrality. So the measured serum potassium is normal or high, even though total body potassium is severely depleted because it has been lost in the osmotic diuresis and vomiting. The correct answer is E. This is why managing DKA requires close potassium monitoring. Once you give insulin, potassium rushes back into cells and the serum level can plummet, risking dangerous hypokalemia and arrhythmia. You must replete potassium as you treat. The serum value masks the true total body deficit, a transcellular shift, not a true surplus. What is the mechanism of action of digoxin? A 72-year-old woman with atrial fibrillation and heart failure is taking digoxin. She presents with nausea, confusion, and seeing yellow-green halos around lights. ECG shows scooped ST segments and a new arrhythmia. Her potassium is low from recent diuretic use. Read the command. Mechanism of action of digoxin. Digoxin with nausea, confusion, yellow-green vision, scoop ST segments, and hypokalemia potentiating toxicity. Digoxin inhibits the sodium-potassium ATPase on the cardiac myocyte membrane. Blocking this pump raises intracellular sodium. The cell relies on the sodium-calcium exchanger to extrude calcium, and that exchanger is driven by the sodium gradient. So when intracellular sodium rises, the exchanger slows and intracellular cell calcium accumulates. More calcium stored and released means a stronger contraction, the positive inotropic effect. Digoxin also enhances vagal tone, slowing AV nodal conduction, which helps control the ventricular rate in atrial fibrillation. The correct answer is C. The toxicity clues are classic: nausea, confusion, and the yellow-green visual halos, with scooped ST segments and arrhythmias. Critically, hypokalemia potentiates digoxin toxicity because potassium and digoxin compete for the same site on the NBME pace. Low potassium leaves more binding sites open. That is why this patient's diuretic-induced hypokalemia is dangerous. Correct the potassium and use digoxin-specific antibody fragments for severe toxicity. What is the most likely diagnosis? A 68-year-old man is found on routine blood work to have a WBC of 45,000 with absolute lymphocytosis. He is asymptomatic except for mild painless lymphadenopathy. Peripheral smear shows numerous mature-appearing small lymphocytes and many smudge cells. Flow cytometry shows a monoclonal B-cell population co-expressing CD5, CD19, and CD25,000 with the population co-expressing CD5, CD19, and CD23. Read the command. Most likely diagnosis: older adult, asymptomatic lymphocytosis, smudge cells, mature B cells co-expressing CD5, CD9, CD23. Chronic lymphocytic leukemia. Chronic lymphocytic leukemia is the most common leukemia in adults in the Western world, typically in patients over 60 and often discovered incidentally on routine blood work. The hallmark cells are mature-appearing small lymphocytes that are fragile and rupture during smear preparation, producing the characteristic smudge cells. Flow cytometry clinches it, a monoclonal B-cell population that aberrantly co-expresses CD5, normally a T-cell marker, along with the B-cell markers CD19 and CD23. CLL is identical in cells to small lymphocytic lymphoma. It is just the leukemic blood predominant form. The correct answer is A. Two complications worth knowing. CLL can cause autoimmune hemolytic anemia, and it can transform into an aggressive diffuse large B-cell lymphoma, Richter transformation. The CD5 positive co-expression also appears in mantle cell lymphoma, choice B, but mantle cell is CD23 negative and carries 23 negative and carries 2311 with cyclin D1. CLL is CD23 positive. The smudge cells with CD5, CD19, CD23 point to CLL. What is the mechanism of the kidney injury? A 4-year-old girl develops bloody diarrhea after eating an undercooked hamburger at a county fair. 5 days later, she becomes pale and lethargic with decreased urine output. Labs: HGB 7.5 with schistocytes, platelets 40,000, creatinine 2.6 mg/dl. Stool culture grows a sorbitol, negative E. coli. Read the command. Mechanism of kidney injury. Bloody diarrhea after undercooked beef, then microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury, sorbitol, negative E. coli. Hemolytic uremic syndrome from E. coli 0157H7. This is hemolytic uremic syndrome caused by enterohemorrhagic E. coli, serotype 057H7, which is sorbitol negative on McConkey agar. The bacterium produces Shiga-like toxin, also called virotoxin. The toxin inhibits the host ribosomal 60S subunit, but its key pathologic action in hips is damaging vascular endothelial cells, especially in the kidney. Endothelial injury exposes the subendothelium and triggers platelet activation and microthrombi in the small vessels. These microthrombi shear red cells into schistocytes, hemolytic anemia, consume platelets, thrombocytopenia, and obstruct glomerular flow, acute kidney injury, the HUS triad. The correct answer is B. The triad of HUS is microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury, classically following bloody diarrhea in a child. Critically, do not give antibiotics in EHEC infection. They can increase toxin release and worsen HUS. Management is supportive. The endothelial damage mechanism distinguishes HUS from immune or invasive renal injury. What is the underlying physiologic problem? A premature infant born at 28 weeks develops progressive respiratory distress within hours of birth. Tachypnea, grunting, nasal flaring, and retractions. Chest X-ray shows diffuse ground glass opacities with air bronchograms and low lung volumes. Rate the command. Underlying physiologic problem. Premature infant, respiratory distress within hours, ground glass with air bronchograms, neonatal respiratory distress syndrome from surfactant deficiency. Neonatal respiratory distress syndrome results from a deficiency of pulmonary surfactant. Surfactant is made by type 2 pneumocytes, beginning meaningfully around 24 to 34 weeks and maturing late in gestation, so premature infants lack it. Surfactant, mostly dipalmitoylphosphatidylcholine, lecithin, reduces alveolar surface tension. By the law of Laplace, the collapsing pressure of an alveolus is proportional to surface tension divided by radius. Small alveoli have the highest collapsing pressure. Without surfactant to lower surface tension, alveoli collapse on expiration, causing diffuse atelectasis, stiff, low-volume lungs, and the ground glass appearance. The correct answer is E. Surfactant maturity is assessed by the lecithin to sphingomyelin ratio, where a ratio above 2 indicates mature lungs. Risk factors include prematurity, maternal diabetes, fetal hyperinsulinemia, delayed surfactant, and C-section without labor. Antenatal corticosteroids accelerate surfactant production, and exogenous surfactant treats it. The Laplace surfactant treats it. What is the underlying mechanism? A 30-year-old woman develops profuse bleeding from her IV sites and gums shortly after delivery, complicated by amniotic fluid embolism. Labs: platelets 40,000, PT and PTT both prolonged, fibrinogen low, D-dimer markedly elevated. Peripheral smear shows schistocytes. Read the command. Underlying mechanism. Obstetric catastrophe, bleeding everywhere, low platelets, prolonged PT, and PTT, low fibrinogen, high D-dimer, schistocytes, disseminated intravascular coagulation. Disseminated intravascular coagulation is a systemic, uncontrolled activation of the coagulation cascade, here triggered by amniotic fluid embolism releasing tissue factor into the circulation. Widespread thrombin generation forms microthrombi throughout the small vessels, which shear red cells into schistocytes. This massive clotting consumes platelets, and clotting factors faster than they can be replaced, so paradoxically the patient then bleeds. Fibrinolysis is also activated, breaking down the clots and generating fibrin degradation products, reflected in the markedly elevated D dimer. The correct answer is B. The lab signature is the key to DIC, both PT and PTT prolonged, low platelets, low fibrinogen, it is consumed, and high D dimer. This contrasts with TTP, where PT and PTT are normal and fibrinogen is normal. The classic triggers are sepsis, obstetric complications, malignancy, and massive trauma. Treat the underlying cause and support with blood products. What is the embryologic basis of this hernia? A 40-year-old man presents with a bulge in the right groin that appears with straining and protrudes into the scrotum. At surgery, the hernia sac is found to pass through the deep inguinal ring, lateral to the inferior epigastric vessels, and travels within the spermatic cord. Read the command, embryologic basis. Hernia, through the deep inguinal ring, lateral to the inferior epigastric vessels, into the scrotum within the spermatic cord. Indirect inguinal hernia. This is an indirect inguinal hernia, and its basis is embryologic failure of the processus vaginalis to obliterate. During development, the processus vaginalis is an outpouching of peritoneum that precedes the testis as it descends through the inguinal canal into the scrotum. It normally closes after descent. If it stays patent, abdominal contents can follow the same path. Through the deep inguinal ring, lateral to the inferior epigastric vessels, down the inguinal canal within the spermatic cord, and into the scrotum. This is why indirect hernias are the most common type and often present in infants and young patients. The correct answer is D. In contrast the two, an indirect hernia goes through the deep ring, lateral to the inferior epigastric vessels and is congenital. A direct hernia choice, E, pushes through the weak floor of Hasselbalch's triangle, medial to the inferior epigastric vessels and is acquired from wound weakness in older men. Lateral into the scrotum, congenital processus vaginalis equals indirect. Which type of error has occurred? And what does the p-value threshold represent? Researchers test a new drug against placebo. In reality, the drug has no true effect, but the study reports a statistically significant benefit, PBU by U by U by U5, and the authors conclude the drug works. Read the command, which error and what the threshold represents. The drug truly has no effect, but the study found a significant benefit, a false positive, type 1 error. A type I error is a false positive, rejecting the null hypothesis when it is actually true. Here, the null hypothesis, that the drug has no effect, is TRU, but the study found a statistically significant result and concluded the drug works. That is a false positive, a type I error. The threshold for statistical significance, alpha, conventionally 0.05, IS, the probability of making a type I error, the chance of falsely declaring an effect when none exists. Setting alpha at 0.05 means accepting a 5% risk of a false positive. The correct answer is D. Keep the pair straight. Type I error alpha is a false positive, seeing an effect that is not there. Type 2 error beta is a false negative, missing an effect that is real. Power equals 1 minus beta, the ability to detect a true effect. A useful mnemonic. A type I error convicts the innocent drug. A type 2 error acquits a guilty one. No true effect plus a significant. Finding is the textbook type I error. A deficiency of which enzyme is most likely? A 10-month-old infant is brought to the ED after a prolonged fast during a viral illness with vomiting. He is lethargic and hypoglycemic. Notably, urine ketones are low or absent despite the hypoglycemia. Labs show elevated dicarboxylic acids in the urine. A defect in fatty acid oxidation is suspected. Read the command, which enzyme is deficient? Infant, fasting hypoglycemia with INAP. properly allow ketones, dicarboxylic aciduria, fatty acid oxidation defect, MCAD deficiency. Medium chain. CoA dehydrogenase, MCAD, catalyzes a key step in the beta oxidation of medium chain fatty acids. During fasting, the body normally switches to oxidizing fatty acids for energy and producing ketones as an alternative fuel. When MCAD is deficient, fatty acid oxidation stalls. The body cannot generate acetyl-CoA from fat, so it cannot make ketones, and it cannot sustain gluconeogenesis. The result is hypoketotic hypoglycemia, low glucose with INAP appropriately, low ketones during a fast. The accumulating medium-chain fatty acids are diverted to omega oxidation, producing the dicarboxylic acids in the urine. The correct answer is B. The discriminating feature is hypoketotic hypoglycemia. In most causes of fasting hypoglycemia, the body makes ketones. The absence of ketones points specifically to a fatty acid oxidation defect, of which MCAD is the most common. These children are at risk of sudden death during fasting illnesses, so the management is simple but critical. Avoid fasting and give glucose during illness. Low ketones plus dicarboxylic aciduria equals MCAD. From which zone of the prostate does this cancer most commonly arise, and what is characteristic of its metastases? A 70-year-old man presents with urinary hesitancy and new low back pain. Digital rectal exam reveals a hard, irregular nodule on the posterior prostate. PSA is markedly elevated. A bone scan shows multiple osteoblastic lesions in the lumbar spine and pelvis. Biopsy confirms adenocarcinoma. Read the command, zone of origin and metastasis character. Elderly man, hard prostate nodule, high PSA, osteoblastic bone lesions, prostate adenocarcinoma. Prostate adenocarcinoma most commonly arises in the peripheral zone of the prostate, which is why it is palpable as a hard, irregular nodule on digital rectal exam, and why it is less likely to cause early urinary obstruction. This is the opposite of benign prostatic hyperplasia, which arises in the transition zone around the urethra and causes obstructive urinary symptoms. The characteristic metastases are osteoblastic, bone-forming lesions, classically in the lumbar spine and pelvis, producing dense sclerotic areas on imaging and bone pain. This is one of the few cancers that makes osteoblastic rather than osteolytic bone lesions. The correct answer is D. The osteoblastic metastases spread through the vertebral venous plexus, Batson plexus, to the axial skeleton. Grading uses the Gleason score, based on the glandular architecture. PSA is the screening and monitoring marker. 2 pairings to remember. Prostate cancer in the peripheral zone with osteoblastic mets versus BPH in the transition zone with obstruction. Which statement correctly describes the apex of the upright lung compared with the base? A physiologist studies regional differences in blood flow and ventilation in an upright healthy lung. At the apex, alveolar pressure can exceed arterial pressure, which exceeds venous pressure. At the base, arterial and venous pressures both exceed alveolar pressure. Read the command. Describe the apex versus the base. Upright lung zones. Apex has lower flow and higher BCQ ratio. Base has higher flow and lower BCQ. In the upright lung, gravity creates a gradient. At the apex, this describes West Zone 1 physiology. Alveolar pressure is high relative to the low arterial pressure, so the capillaries are compressed and blood flow is low. Ventilation is also somewhat reduced at the apex, but flow is reduced MORA. Since the VCQ ratio is ventilation divided by perfusion, and perfusion drops more than ventilation, the apex has a Higg VCQ ratio approaching 3. At the BAC, zone 3, both arterial and venous pressures exceed alveolar pressure, capillaries stay open, and blood flow is high, so perfusion exceeds ventilation and the VIQ ratio is LOW, around 0.6. The correct answer is E. Both ventilation and perfusion are greater at the base, but perfusion increases more from apex to base than ventilation does, so the VCQ ratio falls from apex to base. This regional VCQ mismatch is normal and explains why certain diseases localized. Tuberculosis favors the high oxygen apex, while aspiration and most pathogens settle in the well-perfused base. High VCQ at the apex, low VCQ at the base. Which single factor is the most important determinant of prognosis in this malignancy? A 55-year-old fair-skinned man presents with a changing mole on his back. It is 9 mm asymmetric, with irregular borders, variegated brown-black color, and recent itching. Excisional biopsy shows atypical melanocytes with a vertical growth phase invading to a breast lobe depth of 2.1 mm. Read the command most important prognostic factor. Changing mole, ABCDE features, atypical melanocytes, vertical growth phase, breast lobe depth, malignant melanoma. The single most important prognostic factor in malignant melanoma is the depth of invasion. The Breslow thickness, measured in millimeters from the granular layer of the epidermis to the deepest tumor cell. The deeper the vertical invasion, the greater the access to lymphatics and blood vessels and the higher the risk of metastasis. A thin melanoma is often cured by excision. A thick one carries a much worse prognosis. The transition from the radial horizontal growth phase to the vertical growth phase marks the shift to metastatic potential, which is why depth, not diameter, drives prognosis. The correct answer is E, the ABCDE criteria. Asymmetry, border irregularity, color variegation, diameter over 6 mm, and evolution help you recognize a suspicious lesion, but once melanoma is diagnosed, the breast lobe depth determines prognosis and staging. Melanoma is associated with UV exposure and BRAF mutations, which are now therapeutic targets. Depth of invasion is the prognostic answer. This drug primarily exerts its antiarrhythmic effect by which mechanism? A 64-year-old woman with atrial fibrillation and recurrent ventricular arrhythmias is maintained on amiodarone. At a follow-up visit, she reports a dry cough and progressive dyspnea. Imaging shows interstitial changes. Her TSH is abnormal and liver enzymes are mildly elevated. A fine corneal deposit is noted on slit lamp exam. Read the command, primary antiarrhythmic mechanism. Amiodarone with pulmonary, thyroid, hepatic, and corneal toxicity. A class 3 potassium channel blocker with multi-class activity. Amiodarone is primarily a class 3 antiarrhythmic. It blocks potassium channels, prolonging phase 3 repolarization and lengthening the action potential duration and the effective refractory period. This is reflected on the ECG as a prolonged QT interval. Uniquely, amiodarone has activity across ALL4, von Williams classes. It also blocks sodium channels, has beta-blocking effects, and blocks calcium channels, which makes it broadly effective but also accounts for its complex profile. The correct answer is A. Its toxicities are the high-yield exam point and must be monitored. Pulmonary fibrosis, the dry cough, and interstitial changes here. Thyroid dysfunction, both hypo and hyper, because the molecule is iodine-rich. Hepatotoxicity, corneal microdeposits, and blue-gray skin discoloration. So check pulmonary function, TSH, and liver enzymes regularly. The potassium channel QT prolonging class 3 action is the primary mechanism. Which feature of this organism is the primary virulence factor and basis of the antigen test? A 3-year-old man with AIDS CD4 count 40 presents with 2 weeks of worsening headache, fever, and neck stiffness, and now altered mental status. Lumbar puncture shows elevated opening pressure. India ink staining of the CSF reveals round yeast with a wide, clear surrounding halo. A latex agglutination test for a polysaccharide antigen is positive. Read the command, primary virulence factor and basis of the antigen test. AIDS with CD4 of 40, subacute meningitis, high opening pressure. India ink with a clear halo, positive polysaccharide antigen. Cryptococcus neoformans. Cryptococcus neoformans is an encapsulated yeast and the leading cause of fungal meningitis in advanced AIDS, typically when the CD4 count falls below 100, often below 50. Its primary virulence factor is the thick polysaccharide capsule, made mainly of glucuronoxylomannan. The capsule is what produces the clear halo seen on India. Ink staining. The ink cannot penetrate the capsule, so the yeast appears surrounded by a bright unstained zone. That same polysaccharide capsular antigen is what the cryptococcal antigen latex agglutination test detects, a sensitive and specific diagnostic. The correct answer is C. The capsule is also antiphagocytic, helping the organism evade immune clearance. The high opening pressure is characteristic and often needs repeated lumbar punctures to manage. Treat with amphotericin B plus flucytosine for induction, then fluconazole. The polysaccharide capsule ties together the virulence, the India ink halo, and the antigen test. All three point to it. What is the mechanism of this rejection? A 52-year-old man receives a kidney transplant from a deceased donor. Within minutes of reperfusion in the operating room, the graft turns mottled, cyanotic, and flaccid and must be removed. Pathology shows widespread thrombosis of small vessels with neutrophilic infiltration and fibrinoid necrosis. Read the command. Mechanism of this rejection. Transplant rejection within minutes of reperfusion, small vessel thrombosis, and fibrinoid necrosis, hyperacute rejection from preformed antibodies. Hyperacute rejection occurs within minutes to hours of reperfusion and is mediated by preferent recipient antibodies against donor antigens, typically ABO blood group or HLA antigens, present in the circulation before transplantation, often from prior transfusions, pregnancies, or transplants. On reperfusion, these antibodies immediately bind the donor vascular endothelium and activate complement, triggering widespread small vessel thrombosis, neutrophilic infiltration, and fibrinoid necrosis. The graft becomes ischemic, mottled, and cyanotic almost at once and is not salvageable. The correct answer is C. Know the timeline of rejection. Hyperacute is minutes to hours. Preformed antibodies, now largely prevented by cross-matching before surgery. Acute rejection is days to weeks. T-cell mediated choice. T-cell mediated choice. T-hronic rejection is months to years, with vascular fibrosis and intimal thickening. Choice E. Graft versus host disease is the donor cells attacking the recipient, the opposite direction. Minutes plus preformed antibodies equals hyperacute. Block 7 is done. Let's review the 5 biggest traps from this block. Trap 1. Carbon monoxide poisoning. The PO2 is normal because it measures dissolved oxygen, not hemoglobin saturation, and standard pulse oximetry reads falsely normal. The tissue hypoxia comes from CO occupying hemoglobin and shifting the curve left. Trap 2. The potassium paradox in DKA. The serum potassium reads high from the transcellular shift, but total body potassium is depleted. The moment you give insulin, it crashes, so replete potassium during treatment. Trap 3. DIC versus TTP. Both have schistocytes and low platelets. DIC consumes clotting factors, so PT and PTT are prolonged and fibrinogen is low. TTP has normal coagulation times. Trap 4. Fasting hypoglycemia with LOW ketones. Most causes make ketones. The absence of ketones points to a fatty acid oxidation defect. MCAD is the most common. Avoid fasting in these children. Trap 5. Rejection timing tells you the mechanism. Minutes means preformed antibodies, hyperacute. Days to weeks means T cells, acute. Months to years means fibrosis, chronic. Train process, not memorization. 7 blocks down. You're building real exam stamina now. StepLogic. Learn how to think, not memorize.